All right, everybody, I got another case to present to you guys. This happened just this past week, and this is from one of our residents, Timothy Paraso. I guess it sounds like parasol, and I have a hard time with weird words, so I'm probably pronouncing his name wrong, but he's a good dude. We've only worked together in passing. We usually have a couple hours at the end of our shift that overlap. That's probably on purpose, because if Tim and I spend too much time together, it would form a black hole of depression, like something that only Stephen Hawking could conceive of, and everyone around us would be just sucked down it. So it's for your own safety. All right, so I looked up his name. The surname Paraso, which is a variant of Paraziu, is of French origin. It is a diminutive pet form of the personal name Paris. The suffix eau is a French diminutive, making Parasu translate roughly to Little Paris. Yes, Tim is diminutive. Celtic word pario, meaning cauldron, also fits, diminutive cauldron. And it's one proposed origin for the tribal name, epidemiology. Scholars debate the exact linguistic roots of the mythological name. Oh yeah, because that's the thing. So if it means Little Paris, well, what does Paris mean? So scholars debate what Paris means. Some theories trace it to the ancient Luwian, whatever, language meaning primary or foremost man, while others link it to an Indo-European root, par, meaning to protect, to contain. Yeah, so overall, Tim's diminutive, cauldron. It's fitting that this is his case, and we'll get into that later, okay? So here we go. Remember, the value of any EKG depends on your pretest probability, and we get our pretest probability from the history. So here's what was documented. Patient is a 58-year-old male here for chest pain. He has a past medical history significant for hypertension and type 2 diabetes. He states about 1 hour prior to ED arrival, he woke up from sleep with chest pain. Okay, this was early in the morning because, again, this is when we were passing. I was coming in at 6, and this was the last patient Tim saw at 5:30. Because remember, your platelets get more sticky around the 3 o'clock, 4 o'clock hour, the death hour, the witching hour, like I call it. States he checks his BP at home, which was elevated, systolic in the 180s, millimeters of mercury. Denies any other symptoms, still having some chest pain here in the ED. He reports taking 81 milligrams of aspirin prior to ED arrival. That's cool. So, usually you take 324. If someone's on a baby aspirin every day, according to the recommendations, you only have to give them half of 324. But if you give them the full 324, they have the same outcome as far as coronary artery disease outcome goes. But the higher doses of people who take a baby aspirin, there is some GI bleeding with it. Let's see. He denies any personal history of heart disease, but he states his father had heart disease and died 3 weeks ago of an MI prior to getting stents. Denies a history of stress tests in the past. Okay, so there's our history. Here is a previous EKG. Okay, again, I recommend you pause and go through it. Either think about or write down what your findings are, and then think about what your interpretation is. All right, so we start normally with the rhythm strip down here, which is lead 2. I see 1P before every QRS, so it looks sinus to me, okay? The rate, normal to fastest, but nothing crazy, okay? So now for axis, it's up in AVF and up in lead 1, so normal. For intervals, the QRS is, let's see, we got about 2.5 boxes. It's not completely wide, but it's close. We also have no prolongation of the QTC. All right, for ST segments, first thing I do is here look at AVL. The T wave is upright, which is normal. I don't see any J-point deviation in this lead. Lead 1, the T wave is upright, which is normal. We got a little bit of an S wave, but nothing crazy. I don't see any J-point deviation. Lead 2, and we got a little bit of inversion here and flattening in lead 2. The J-point, not much deviated though. Okay, that's just non-specific. Excuse me. Down here, again, we have inversion linear of the ST segment, but again, no J-point deviation. The J-point is lining up with the PR segment. A little bit of a fractionated QRS here, which can be a sign of structural heart disease. Same thing in AVF. Again, we have this linearity and inversion of the ST segment, but no significant J-point deviation. And again, this mild fractionated QRS. Up here in AVR, the T wave is inverted, which is normal. And again, I don't see any J-point depression, which is reassuring. Up here in V1, T wave a little bit flat and inverted, again, which is normal. Again, incomplete, but not full, greater than 120, no J-point deviation. Here in V2, I do see some J-point deviation, approximately maybe 1 millimeter, okay? Here in lead 3, we got some wandering here, but let's look down here. The T-wave's upright, and I'm not really seeing much J-point deviation, maybe a 0.5 millimeter, okay, but hard to tell. V4, no real J-point deviation, T-wave upright, maybe 0.5 millimeter of J-point deviation, T-wave upright. Again, maybe a 0.5 millimeter here and T-wave upright. So overall, I don't want to see anything pathologic. We got good R-wave progression here because the R-wave's over 3 millimeters. I mean, this drastic approach jump here from this to this could make me suggestive of either pulmonary process or like right ventricular hypertrophy. But overall, non-diagnostic, no acute signs of infarction, ischemia, or arrhythmia. And remember, that's just to establish a baseline. Now, so remember, this guy comes in, chest pain, and here's the EKG that we have. So again, pause and go through it, but here's what Patrick sees. So we got the rhythm strip, again, 1P before every QRS, sinus, maybe normal to fast, but nothing crazy. Up in AVF, up in 1, so normal. Again, let's see for the QRS. We got the same thing, like 2.5 boxes, still not a bundle branch block. The QT is not prolonged. Okay, let's look at our ST segments. AVL is upright, which is good. No real J-point deviation. We do have maybe a 0.5 millimeter of J-point deviation here in these leads in lead 1. Okay, which was new from the last time, which I remembered. Here in 2-3 AVF, again, we do have maybe not much J-point deviation, but we have straightening of this ST segment here. Okay, here we have maybe a 0.5 to 1 millimeter J-point deviation, and again, straightening of this segment here. Same thing as before, not really, it's maybe like 1 millimeter or 0.5 millimeter J-point deviation, some linearity. Up here in AVR, I do see some J-point deviation, maybe about 1 millimeter, and again, linearity. Up here in V2, well, now the T wave is upright, and I do see approximately 1 millimeter of J-point deviation, okay? Remember, it's normal to have an inverted T in V1. Anytime I see an upright T wave in V1, especially in someone who's got chest pain, I immediately go down and look at V6, okay? And what you're looking for is loss of precordial T wave balance. Remember, normally you should have a T wave that's bigger in V6 than V1. Anytime you have an upright T wave that's larger in V1 than V6, that's concerning. It's called loss of T wave balance or new upright T wave, can be a sign of LAD problems. Okay, so down here in V2, I do see J-point deviation as before, maybe 1.5 to 2 millimeters, relatively hyperacute T wave here. Okay, down here in V3, I'm not seeing much J-point deviation, a little peaking of the T wave. V4, not much J-point deviation, but we have this linearity here. V5, I am seeing some J-point deviation of about 1 millimeter and some linearity. And same thing down here in V6, I am seeing about 1 millimeter J-point deviation and linearity. Okay, so overall, my interpretation for this is concerning for active ischemia. Like, is it an infarct? No, we went over that before. It doesn't meet criteria. It's not contiguous leads in his age. He's a man over 40, so you have to have more than 2.5 in the precordial leads and 1, in the other leads. In the contiguous leads, which we don't have here. Okay, so the guy, looks good too. Whoops. So what happens with him? So here's his labs. Okay. His last time they checked his proton was 4. First one was 14, then 64, 165, 189, and 49. Okay, so he goes to the observation unit. They follow the tropes, and they're like, all right, we'll just cath you. Okay, he goes to cath, and he's got a 3-vessel disease here. Whoops, sorry. Whoa, what's going on here? Here is his RCA. We do have some disease here, again, but not completely occluded. What are you doing, Patrick? Here's his LAD. Look at this. Look at all of that, stenosis. It's almost completely occluded. And again, other disease areas down here, out through here, throughout the LAD. Here's another picture down in the LAD, and you can see some just disease diffusely here and stuff like that. Here's it when they're ballooning up, so they put 2 stents in. So 90% stenosis of the proximal LAD, 80% mid LAD, put 2 stents in, continue medical therapy and stuff like that. Okay. So again, a recurring thing that you talked about before, this patient's not a STEMI, but he had risk factors, he had symptoms, he had focal repolarization abnormalities, and eventually he had enough disease that needed intervention. Sorry, I need a sip of my soda. All right. This recurring thing I talk about all the time, how STEMI is irrelevant, and we should think about symptoms, risk factors, and focal repolarization abnormalities. We've gone through this, how we do that as far as like clinically and evaluation and stuff. But I've come up with a way to do it objectively, okay? I call it the Iraje, all right? It's a high sensitivity ACS scoring system. So this is a tool, all right? For tools, the value and safety of any tool depends on a number of things. Number one, it depends on what the tool is designed for. Number two, who's using the tool. And number three, what they're using it for, right? Like a hammer is a tool. Like an expert carpenter can use a hammer as a tool to construct you a house to live in to protect your family from the elements. Or a deranged, crazy person can use a hammer to bash your skull in, right? Like the hammer's not like inherently good or bad, just it all depends on what you're using the tool for and how you apply it for. So this doesn't work for everything. This is to evaluate ACS, okay? So let's go through it. Okay, Iraje. Why is this all jacked up? So the I stands for inversion. Okay, it's AVL, inversion in AVL, which is new onset. If you have that, that's 1 point, okay? The thing about this tool, and again, how it works, is these findings we're going to talk about have to be new onset. So if you don't have an old EKG to compare to, you can't use this tool. Okay, remember, like the value and design for the tool. So if you can't confirm these are new onset, then you can't use these rules and this doesn't apply. Okay, and what I'm saying, inversion in AVL, if any segment of the ST wave is below the PR segment, it's inverted. So, and the PR segment for this tool is the main starting point for all these measurements we're going to do, okay? R stands for risk, okay? If you have 3 or more of the classic cardiac risk factors, or if you have like known cardiovascular disease, like if you've had a heart attack before, or you've had some vascular problem before, like a TIA, a stroke, peripheral vascular disease with a FEMPOP bypass, then you get 1 point for that. Like this is establishing our pretest probability. Like I've said before, every patient you see has coronary artery disease. The question is not do they have it, is do they have a pathological amount and how fast do I need to fix it? So that's what this tool is for, is like, does this patient have a pathological amount of coronary artery disease? And the risk factors is what's important for it. And again, you only get 1 point for risk factors. Like if you have 3 or more risk factors and a history of a previous like heart attack, like you can't get 2 points. There's only 1 point for that, okay? A stands for active, okay? That means symptoms while the EKG was done, okay? Like that's very important. Like you had to have symptoms going on while the EKG was done. And again, I say symptoms, not necessarily chest pain, okay? Like any anginal equivalent, okay? Diabetics, especially diabetic females, are notorious for having atypical signs and symptoms. You ask them, do you have pain? Well, no, I don't have pain. I just have this, back tightness, or I just feel nauseous, or I have this indigestion, or I just feel tired or weak, or I feel short of breath. So did the patient have active symptoms while the EKG was done? If the answer is yes, then it's 1 point, okay? The J stands for J points, okay? And it's for J point deviation, okay? Again, specificity of language. Like I said deviation. I didn't say elevation or depression. If the J point is deviated 1 or greater than 1 millimeters from the PR segment in contiguous leads, then you get 1 point for each set of contiguous leads. The other thing that's different about my approach is, I use a different definition of contiguous leads. The contiguous leads I use are 1 in AVL, 2, 3 in AVF, AVR and V1, V2 through V3, and V4 through V6. And again, this has to be new onset, okay? So you get 1 point for each contiguous group, okay? So you can get like 1 point for AVL and lead 1, 1 point for 2, 3 in AVF. So you get a maximum of 1, 2, 3, 4, 5. You can get a maximum of 5 points just from the J point deviation alone. Sorry how this got cut off. This is weird. Okay, so E stands for exertion. Okay, if the patient has their symptoms are worse with exertion, then it's 1 point. Okay, if your Iraje score is over 5, that means you need a cath. All right, so let's go back. You can make this as just objective as possible. This is just simple, like yes or no. Okay, so for the I, like Is there new inversion in AVL? Yes or no? The answer is yes, 1 point. Okay. Risk factors. Do they have 3 or more risk factors or known vascular disease? Yes, then 1 point. Okay. Do they have symptoms while the EKG was done? Yes, then 1 point. Okay. Then you go through here and you go to each contiguous leads and you're like, all right, in 1 in AVL, do they have more than 1 millimeter J-point deviation? The answer is yes, 1 point. Same thing with 2-3 AVF. And again, like you ask your patient, well, is this worse with exertion? And they say yes, that's 1 point. Okay, so technically, you only have to ask the patient a couple of questions, right? Like, do you have risk factors? Do you have pain right now? Is it worse when you exert yourself? Like, those are the 3 things you only really need to ask to use this tool. Okay, so as I said before, during this tool, my definition of contiguous leads is different. Here's the classic one, okay, 1 in AVL, 2-3 AVF, V1 through V2, V3 through V4, V5 and V6. And here's AVL up here by itself, all alone on an island. And that's why it's pertinent that Tim had this case, because Tim is AVR, okay? Tim is an island alone to himself, which I respect and I agree with, okay? Like, just look at him up here. Now, you guys' contiguous leads are stupid. I don't want to be part of you. Like, that's Tim right there. So that's the classic ones, okay? These are the ones that I use, okay? 1 in AVL, 2-3 in AVF, AVR and V1, V2 and V3, V4, 5, and V6. So that's, for this tool alone, that's what I'm saying when I'm saying contiguous leads, okay? So again, let's go through this again and let's use our scoring system, okay? So for, let's go through and look at it. So he's got he's got age, he's over 55, hypertension, diabetic, and family history of coronary artery disease. Okay, so he's already got 1 point for that. He's got 3 or more risk factors for coronary artery disease. Still having some chest pain, okay? So we got 1 point for risk factors. We got 1 point for active pain, okay? There's nothing in here about it getting worse with exertion, so I can't really use that for a point, okay? Now, let's go through his EKG, okay? So I have them side by side. I have the old one and the new one. So, our first grouping, our first contiguous leads that we talked about is AVL and lead 1. Okay, so here we go. And the questions we're asking. So the first question is, well, is there new onset inversion in AVL? The answer is no. So we don't get a point for that. Okay. Now the next question is, well, is there J-point deviation of 1 or more millimeters in these two contiguous leads? And let's look. Okay. Here we are at AVL. I'm not really seeing much J-point deviation. Okay. I do have maybe some J-point deviation here, I don't know if I'm comparing this, but here's the new one. I do have some J-point deviation of about 1 millimeter up here in lead 1, but it's not 2 contiguous leads, right? They're not both in 2 leads, so we get no points. So for our first one, we get 0 points. We did not have inversion in AVL. We did not have J-point deviation contiguous leads. All right, so let's go on to our next lead, okay, which is 2-3 in AVF. Here we have the old ones on the left side and the new ones on the right side. So what we're looking for, the question is, well, do we have J-point deviation of 1 or more millimeters in 2 of these leads? So let's look at lead 2. Here's the PR segment. There's the J-point. There is 1 millimeter, so we got 1 there. Let's look at lead 3, okay? There's the PR segment. There's the J-point. Nope, doesn't qualify. Let's look down here at AVF. There's the PR segment. There's the J-point. Yep, we got 1 millimeter there. Okay, so we have 2 leads in this contiguous group with 1 millimeter. Now, is it new onset? Yes, it is. Here, I didn't have this J-point deviation. Here, I didn't really have this J-point deviation. So for this, the contiguous lead, we get 1 point. Okay, so far, remember we had 1 for risk factors. Okay, 1 for active pain. Okay, now we're at 1 for this contiguous lead. So right now our score is 3. All right. Now, let's go on to the next set of contiguous leads. Remember, the question we're asking is, do we have 1 millimeter of J-point deviation in these leads? And let's look up here. Here is our PR segment in AVR. And yes, we do have 1 more millimeter of J-point deviation in this lead. Let's look at V1. Here is our PR segment. There is our J-point. And yes, okay, we have 1 millimeter of J-point deviation in this lead. So for this group, we get 1 more point. So we had 1 for risk factors, 1 for active symptoms, 1 for the J-point deviation in those contiguous leads, another 1. So now we're up to 4. We're creeping up there. I'm getting nervous for this man. Okay. So, whoops. No, what are you doing? Ah! Let's go on to our next set of contiguous leads, which is V2 and V3. Again, what we're looking for is new onset of 1 millimeter J-point deviation in these leads. Here is our PR segment in V2. Here is our J-point in V2. And yep, we have more than 1 millimeter. Okay. Here we go in V3. There's our PR segment. There's our J-point. No, we don't have 1 millimeter. And, not so. Here we get 0 points. 0 points. So we're still at a score of 4 here. Okay. Let's go on to the next set of contiguous leads, which is V4, 5, and 6. And again, what we're looking for is J-point deviation of 1 millimeter in any two of these leads. Here we are in V4 in the new segment. Here's our... I apologize to everyone. I am with the... Okay, I guess my pen's broken. Okay, here we go. Up in... Son of a... I apologize. Okay, so here we go. What am I doing? I'm going to have to start this whole freaking thing over. Okay, here we go. V4, 5, and 6. Sorry, I mixed up the new and the old, but what you're looking for is there more than 1 millimeter J-point deviation in two contiguous leads. Here's V4. There's our PR segment. There's our J-point. So no for there. Now we have 1 millimeter in V6. So there's 1. And now we have V6. So yes, we have two contiguous leads. So now we're up to a score of 5. Okay, so he had an Iraje score of 5. He needs to go to the cath lab, which we saw in this case. Now, that was just one case to show you. Sorry, I got to get another drink. This is the case I presented last time. Remember this guy, the guy with VFib arrest? So let's look at him, okay? So patient arrives complaining of chest pain. So we've got active pain. So we got 1 point there. Says that chest pain is constant pressure and pain has been present for 20 minutes. And he's got a history of coronary artery disease. Okay, so we got 1 point for active symptoms. We got another point for risk factors, okay? And again, we have his previous EKG, and we have the new one. So let's go through and look at it. Okay, so the first question is, what we're looking for is I or inversion in AVL. Do we have inversion in AVL, which is new onset? Yes, we do, okay? Remember, if any point of this ST segment is below the PR segment, that's a positive. So we're at 1 point, okay? So we had 1 for active symptoms, 1 for history of coronary disease. Now we're at 1 in AVL, so we're at a score of 3 so far. So now let's look at our contiguous leads, and what we're looking for is J-point deviation. Here in AVL, I don't see any J-point deviation. I do see it in lead 1, not too contiguous, so there's 0 points for that. In 2-3 AVF, I do see 1 millimeter of J-point deviation contiguous leads, so that's another point. So now we're up to 4, okay? Let's look at AVR and V1. Am I seeing 1 millimeter of J-point deviation? Yes, I am. Okay, so now we're up to 5. So 5, this guy needs the cath. And again, I can confirm these are new onset because we didn't have these before. Let's keep going. Now V2 and V3, is there a J-point deviation? None in V2, maybe a half in V3, so we get 0 points there. V4, 5, and 6, not much in V4. V5, yes, I have 1. V6, yes, I have 1. So we're at a total of 6. So this person's total score was 6. And remember, they had coronary artery disease, okay? So let's, again, we look at this case, which we've seen before, right? Patient is 58-year-old female with a history of AFib and hypertension who presents to the ED complaining of chest pain and back pain. So 1 point for active pain. Patient statement is getting worse for the past few months. Her doctor put her on a heart monitor. The last day of the monitor was the previous Sunday. States since then she's been having severe chest pain that would often relate to her back, endorses dizziness, lightheadedness. She states she cannot walk long distances before she needs to stop because of the pain for the last 3 to 4 days. Denies nausea, vomiting, abdominal pain, and risk factors. So let's look at let's use our scoring system. So for risk factors, we got age, we got AFib and hypertension. So we don't have more than 3 or a history of vascular disease. So we get 0 points there. Comes in complaining of chest pain. So we got 1 point for active chest pain. Worse with exertion. Okay, cannot walk for long distances. Worse with exertion. So 0 for history, 1 for active pain, 1 for worse with exertion. Okay, so far we're at a score of 2. Here's the previous EKG. Okay, note, we're looking at there's no inversion in AVL. I'm not seeing much J-point deviation. Maybe like a little here, okay, but that's just for the baseline. Here's the one we have upon presentation, okay? Again, let's look at it. So remember, so far we're at a 1 for active pain, 1 for worse with exertion. First thing, let's look at AVL. And the question is any point of this ST segment below the PR segment? The answer is yes, so we're at 1, okay? So we got another 1 point for AVL. Let's go look through our J points, and we're looking for J point deviation of 1 millimeter in the contiguous leads that I defined. So AVL on lead 1, there's 1 millimeter. Lead 1, there's 1 millimeter. Okay, so we have 1 point for that. We're up to 4. Let's look at 2, 3, and AVF. Okay, there's the J point. Yeah, I got 1 millimeter there. This is not looking good for you, lady. Got 1 millimeter there. No millimeters there, so there's 1 point. Okay. Boom, we're already at 5. Okay. We already know this person needs a cath. We're already at 5. But let's continue for science sake. Okay. AVR and V1. Yes, I have J-point deviation here. No, I do not here. Okay, so a score of 0 for that one. V2 and V3. Yes, I have J-point deviation. V2. Yes, I have it in lead 3. So there's 1 point. V4, 5, and 6. There's 1 with J-point deviation, another with J-point deviation, another point, so another 2 points. So we're at 5 plus 6 plus 7. So the total score is 7. So this person needs a cath, which they did, right? So let's proceed to another case, okay? These are, again, cases I presented before. Patient presents to the emergency department for chest pain. EKG was done in triage concerning for inferior and posterior STEMI. Made STEMI alert. Denies history of diabetes, cocaine, smoking, or pre-causation coronary disease. Okay, so there we go. So we get no points for risk factors. Does not see a cardiologist. Denies use of anticoagulation medication. Denies difficulty ambulating, extreme nose weakness, or tingling, or visits no other clinics at this time. So far, we're only at 1 point for active pain. There's nothing in here about exertion, and we have nothing on here for risk factors. Again, here's a previous EKG just to establish the baseline. The things I note already is AVL is upright, and I'm not seeing much J-point deviation. Okay, so I do see a little here, but I don't see anything crazy. And again, let's look at her EKG. Okay, remember, so we had 0 for risk factors. Okay, we had 1 for active symptoms. We had nothing, for exertion. So let's look. So the first thing is AVL. Is it inverted? Yes. Okay, so 1 point for AVL. Now let's look at our J points. Okay, contiguous leads, 1 in AVL. I do see 1 millimeter there. I do see 1 millimeter there. So another point. Okay, let's look at 2, 3 AVF. I see none in 2. I do see 1 in 3. Maybe half. I don't see 1. Nope. So I get 0 points for 2, 3 AVF. Let's look at AVR and V1. I see 1 millimeter in AVR, and I see 1 millimeter in V1. Okay, so we get 1 point here. Now this is what I'm talking about. This is why I specifically say J-point deviation. Okay, I don't care if it's elevation or depression. If the J-point is deviated, then that counts. This is an elevation. This one is depression. I don't care. I care that it's deviated. So you get 1 point for that. Okay. Another point. Now let's look at other contiguous leads, V2 and V3. I see 1 millimeter. I see another millimeter. So 1 point. V4, 5, and 6. I see 1 millimeter in V4. I see maybe a half in V5, so that doesn't count. And I don't see enough in V6, so that doesn't count. So we get 0 points for this. So we were at 1, 2, 3, 4, 5. 5. Score of 5. Needs to go to the cath lab, which she did, and she had an infarct. The other thing is, even if we don't do all that stuff, if we don't use a scoring system, just note the things that we do see on here, okay? Like I said, number 1, the inversion in AVL. Okay, again, not only the inversion in AVL, but the linear of the ST segment compared to the amplitude of the QRS greater than 1/4. Right? Remember how I said before, for me, that's the most sensitive and concerning sign. Not only that, but we have J-point depression in contiguous leads, okay? We have this biphasic T wave here in lead 3. Same thing in lead AVF. Again, like not enough elevation to qualify, but we do have deviation there. Again, we have elevation in AVR. Again, elevation in AVR with linear ST segment that's greater than 1/4 of the empty QRS, which in the proper clinical setting can be a sign of like 3 velocities or proximal LED occlusion. We also have R waves with ST depression in 2 contiguous leads, right? Like that qualifies for a posterior infarct because we flip this over, these become Q waves and ST elevation. Not only that, but look, we have an T wave in V1 that's bigger than V6, right? Loss of precordial T wave balance, like we've talked about before, a sign of LAD problems. And also in V2 and V3, not only do we have the depression, but we also have the linearity that's greater than 1/4 of the amplitude of the QRS. And same thing, over here in V4 and V5, you have this J-point deviation, this linearity, right? Because like the experts say, there's many different ways to get to the top of the mountain. Like, I don't care what you do, whether you just look at these things and you see it, or you go by the criteria where it's a posterior, or you're using my tool. Like, that's what I'm talking about, right? Like, it's the whole point behind this. Whether you call it, posterior, inferior, it's got a name associated, like a Wellens wave at the Winters, like, I don't care. Like, what it is, it's a focal repolarization abnormality. And often when the patient has symptoms or risk factors, like, that's what it is. Like, that's the whole point of this. Again, here's the interesting thing. I mean, you can, again, like this tool, ideally this tool is like completely objective. Like, you just have to ask the patient like 2 questions and have an old EKG, and like that's when you can apply the rule. The thing is, I mean, technically you can qualify just on the J points alone. Like, so I can't use this tool. So these are cases I found online, but I can't apply this tool to them because I haven't seen the patient. Like, I don't know what their risk factors are. I don't know if they have symptoms. But I mean, the thing about it is, that's why I divided up into these 5 leads, because if you get the J points alone, then you can qualify. So let's look at this one. So I know nothing about the history, but let's go through our scoring tool. Okay, so question number 1 is AVL. Okay, is any point of this ST segment below the PR segment? Yes. So we get 1 point for that. Okay, now let's do our J points. First contiguous lead is AVL lead 1. Yes, more than 1 millimeter. It's kind of hard here because the artifact, but yes, we have 1 millimeter. Okay, so we're at 2 points. Okay, let's go to 2-3 AVF, and again, we're looking for J-point deviation. 1 lead, 2 leads, 3 leads. Yep, so another point. I mean, it's fairly obvious, and it's wicked, higher than 1 millimeter, but it's still more than 1 millimeter. Okay, so our next one is AVR in V1. In AVR, I am seeing a millimeter of deviation, and I'm seeing it in V1 too here. And again, like, yes, technically this is depression, and technically this is elevation, but I don't care. Okay, the word is deviation, and the rules are more than 1 millimeter, so it qualifies, so 1 point. V2 and V3, I see deviation here. Ooh, I don't see any here. So 0 points. 0 points for that one. Let's see, V4, 5, and 6. Yes, J-point deviation. Yes, J-point deviation. No J-point deviation, but I have 2, so 1 point. So we are at 1, 2, 3, 4, 5. C5 needs emergent cath. So that was one case. Let's look at another one. And again, let's just go through the scoring system. So first question, is there any part of the ST segment that's below the PR segment in AVL? Yes, there is. 1 point. Now let's look at our J-point deviation contiguous leads. AVL, I do see more than 1 millimeter. Lead 1, I see more than 1 millimeter. So yes. 2-3 AVS, I mean, obviously, right? Even Tim alone on his island can see this. 2-3 AVF, so yes, 1 point. Let's look at AVR and V1. I have deviation, so yes. Okay, it just so happens they're both, depression, but I don't care, again, it's deviation. Here I have, deviation in V2 and V3, so the answer is yes. Again, you can use all the other things, like this is a posterior, and again, look at the straightening with a 1/4 and like the horizontal or downsloping and like the tombstoning and all that stuff. But again, we're just using the tools here, right? Next question is V4, 5, and 6. Do I see deviation? Yes, I do. Okay, so we get 1 point for that. Plus 1, so 1, 2, 3, 4, 5, 6. 6 needs cath. It's over 5, right? So let's go to another case from the interconnected web of computers. So first question, is there any inversion AVL? The answer is no. So we get an X for that. You suck. Next question, J-point deviation. Yes, I have an AVR. Do I have in lead 1? Yes, I do. Well, I can't blow it up. Well, it's to be injected with our tools. No, we don't, Patrick. No, you don't. So we're at 0 points so far. Ooh, I hope this one qualifies. I don't remember if it does. So let's go to our next set, 2-3 AVF. Do I see 1 millimeter J-point deviation? Yes, I do. So 1 point. So 0 plus 1. Let's look at AVR. Do I see 1 millimeter? Or do I see? Yep, I do in V1. So plus 1. We're making a rally. V2 and V3. We have 1, 2, plus 1. 4. V2 and V3. Yes, we do. Oh. 4. Oh, is this 1 millimeter? Okay. Like, to be honest, like, I'm biased. Like, I do think there's 1 millimeter here. It's just hard to say because, like, it's kind of crappy. Like, you can see it here. Like, if I could clean this up. So, yes, I am saying, okay, I'm sorry. I'm not cheating for the score, but I really think it is. Okay, so we're at 5. Okay, so I'm sorry. Like, yes, I'm a human being. I'm biased. I'm sorry. It's a 5. There's 1 millimeter there. I swear to you. You know, I'm going to go back and find this website. I'll get back to you. Patrick will get back to you on this one. All right. Another case from the interweb. All right. First question: is there any inversion AVL? The answer is no, so I get no points for that. J-point deviation, yes. J-point deviation, 1 point. Ooh, no J-point deviation there, but yes, I still have it in 2 leads, so 1 point. J-point deviation there, J-point deviation there, 1 point. J-point, J-point, J-point. Oh yeah, I do. And here we go. So 1 point. So we got 1, 2, 3, 4, 5. 5, a score of 5. Okay. Well, this is cool. I got another one. All right, let's see. So first question, is there any inversion in AVL? The answer is, well, yes. Okay, so we got 1 point for AVL. Let's look at our J-point deviation. Yep, I'm seeing 1 millimeter here. Okay, so 1 plus 1. Okay. Why is this red all of a sudden? This is weird. I don't see much J-point. Well, maybe I do. There. Okay. Well, nope. I'm being objective, so that's a 0 point. Let's see. AVR and V1. Yep, I see 1 millimeter, so 1 point. So we're at 3. Do I see it in V2 and V3? Yes, I do see 1 millimeter, so we're at 4. Let's see. Do I see it? Yes, I do. V5 and V6, 1 millimeter. So we're at 5. Okay. And again, like I'm saying, like technically, that's not what this tool is for. Like this tool is for in conjunction with their, symptom risk factors and nuance it. But like I'm just showing you like the concept, right? Like it's how to objectively evaluate for a focal repolarization abnormality. So the last one. That was the last one. Okay, so that's a lecture I have for here. And again, the summary for this lecture is, I talk about all the time. Instead of thinking of it as STEMI, we should be thinking of it as, symptoms, risk factors, and focal repolarization abnormalities. Because every patient has age, every patient has coronary artery disease, just like saying every patient has age. And the same thing with age, like the amount and the variation of coronary artery disease you have will depends on things, right? Like, yeah, a 3-year-old and a 90-year-old, they both have age, but those two ages mean totally different things. And for the same instance, like I've seen 35-year-olds who look like they're 85 because of like the way they live their life. So it's the same thing with coronary artery disease. The answer is, well, yes, my patient in front of me has coronary artery disease. Well, how much do they have? And so you taking into account, well, their risk factors in their story, right? So you take into account like their symptoms, their risk factors, and focal repolarization abnormalities, and then do it objectively this way. It's a way to say, well, objectively, yes, this person has a pathological amount of coronary artery disease and needs to go to the cath lab. So I got to sip my soda. Again, this is a tool, and you can't apply it for everybody or every EKG. It's only for the proper, clinical setting. And again, it's highly sensitive. Okay, just because, in my opinion, just because yes, this is positive. I mean, 100% of the time doesn't mean they're going to have coronary artery disease. Because I've seen it before. Like everything points in. It's not like very often, but everything points to coronary artery disease, and you're surprised like when their cath is normal. In my opinion, a very low percentage of time. But again, I have no data to back this up. So that's the other thing is like, I don't care what you do with the score, but you guys are all residents and there's med students and stuff. If one of you younger people, it's going to be here for 3 years, wanted to talk about a project for this, that would be pretty cool. Like we could look at people who come in from the emergency room and get admitted for chest pain and those amounts, that go to get a cath and then like apply this scoring system to come up with like sensitivity and specificity and stuff like that. I mean, that would be an interesting study. Like, again, I don't care if someone does that, anybody. I don't care if some dude in frickin' Australia's listening to this and he wants to, like, I don't care. Like, that's, go ahead and do it. But that's the thing is, this tool is not for me. It's just for something to use and think about. And more important than the tool is the concept. Like, the concept is, my patient has coronary disease. How much do they have and how fast do I need to fix it? And how do I evaluate that? For this, again, just because this Iraje score is 5, I mean, yes, they need a cath, but the next question is, well, how soon? And for me, clinically, it's like, well, what's going on with my patient? How they look, how bad do they feel? Can I control their symptoms? Like this guy, I didn't see him, but I walked past his room a bunch of times, and he looked fine. He's like talking to his family and stuff like that. His pain went away. So that guy, cool. You're like, yeah, I don't need to rush him off the cath lab right away. The other guy who's like, man, I just don't feel good, and is pale, and his family's like hitting the call like, man, he doesn't feel good. He's diaphoretic and stuff like that. Like even if you had the same finding, like, well, I need to do this now. So that's what I have for this one. I know it was longer than usual, and there was a bunch of technical difficulties, and I apologize, but I'm not doing this again because I'm freaking lazy. If you like it, great. You can write me comments. You can talk to me about it in real life. The Iraje score, and it's so fitting because I am full of rage, and so is Tim. That's all I got. I hope you enjoyed it. Peace out. Testing, 1, 2, 3, testing. You gotta be fucking kidding me.